Welcome everyone to this symposium entitled Measuring Program Success. I'm Laura Quilter from the Division of STD Prevention at CDC, and I'll be moderating this symposium with my colleague Brandy Maddox, who's also in the Division of STD Prevention. During this session, we will hear from 4 presenters who will each provide a unique perspective on measuring STD program success. I do want to remind you that there will be a live question and answer session for this symposium on Friday, September 18th at 2:50 p.m. Eastern Standard Time. Our first speaker is Dr. Marian Carter. Dr. Carter is a social scientist by training and currently is the team lead for evaluation in the Program Development and Quality Improvement branch within the Division of STD Prevention at CDC. And that is a role she's had for 7 years. Prior to that, she worked for CDC's Division of Reproductive Health and the Global AIDS Program. Today, Dr. Carter will be presenting on the CDC perspective, lessons learned from our successes and challenges. Dr. Carter?
Great, thank you. I'm happy to be joining my fellow speakers today for this symposium, and thanks for the organizers for inviting me. First, I just want to emphasize that what follows is my opinion and does not represent the official position of the CDC. And for this presentation, I'm drawing primarily from the last 7 years or so as evaluation team lead. In that role, we've been working with health departments to identify and use performance measures for our major cooperative agreements for STD surveillance, prevention, and control. The team has also been involved in conducting and supporting evaluation with health department STD programs and providing technical assistance. So this is a very federal perspective on measuring success that I'm sharing today. Here are the main points I'll try to make today based on the successes and challenges that we've faced in measuring program success. This represents my outline as well. So let's start with the first one, that the discussion of measuring success needs to be clarified and reframed. First, measuring success often conjures up a particular image, right? Measure evokes quantitative data, which can then be applied to a common ruler. Success evokes a situation in which you have achieved some ultimate goal. You've made it, right? Both have often made us all squeamish within public health, I think, where recipients and programs differ so much and where we face many challenges that remind us that we are far from in programmatic heaven. Moreover, what success are we talking about? Take this overly simplified schematic where we have Congress and HHS allocating funding to CDC, which then gives funding to health departments across the US. Simultaneously, other government entities like state houses or city councils also give funding for the work. So are we measuring the success of just CDC's funding to state and local health departments? Or are we measuring the success of each state or local health department's own STD program as a whole? Or are we measuring the success of the entire public health infrastructure for STD prevention? Then success according to whom? According to HHS and Congress? From CDC's perspective, the State House perspective, or a health department's? Each stakeholder has different interests and perspectives. These interests may overlap, but they are distinct. One take on success will not meet all these needs, but this is often what we've tried to do with our performance measures. So take this graph of data from health departments from 2017. This is directly from a previous performance measure report that my team generated. It compares these programs' data on syphilis among women and related partner services metrics. The performance measure is in purple on the far right here as the disease intervention rate. You don't need to review the details. You can see the gist. We have numbers, we see differences, but do we see success? Yeah, no, we don't, right? It's not obvious. There are no benchmarks or targets. There's no context, very little context. And depending on who picks up this graph and when, it could be a deflating experience or just unproductive. So what's a better approach? First, we should be explicit about what we're measuring the success of. In this example, it's each health department's disease intervention program for women with syphilis. And then we should also be explicit about the perspective and intended use. Here, that graph was made for program staff to promote peer-to-peer exchange. We should change the language so that measuring success becomes something more like sharing progress. And ideally, such information is also interpreted alongside other information with more context, like this. So here we combine those measures with, say, trends in in this same measure, right? It's like, how did each area compare over time? We combine that with surveillance data about syphilis among women. We could combine it with recipients' own reports on their relative growth in this area, include it with some qualitative data describing program challenges, and why don't we throw in some success stories while we're at it? So with this kind of information, we could have a robust joint discussion of how programs are progressing on their work on partner services for women with syphilis. You might ask, well, wouldn't another solution just to be to add a benchmark or common target, and then we can see who's successful or not? I would love to do that, but to do so, we need evidence that reaching a particular target matters, and it matters to a public health outcome, right? We need consensus that the measures we're using are appropriate, and we need to have confidence that reaching XYZ target can be reached, right? Or that it's actually reachable, because targets that are unreachable are not inspiring. Let's just put it that way. So in the absence of that, we were trying to just show relative progress and comparisons. We could ask each area to set their own target, and we need to keep asking the hard questions about whether we are measuring success through this exercise. Now I want to move on to my second related point, which is that the good is better than the perfect in this realm. So one aspect of perfection we need to let go of is perfection in indicators. In my experience, this has proven very tricky to do with health departments' work. Identifying strong common indicators has been really challenging. We rarely feel we are hitting the target with these. There's no national quality forum for the work of a quality health department, as there is for identifying measures of quality clinical care. There's little consensus on what should be measured. I have personally been involved in many rounds of discussions on what to measure to reflect the work and performance of our funded programs, and I suspect that is not over. And part of the issue is that much of what matters has been hard to reflect in clean indicators. For example, the extent to which a health department influences providers, or to which they partner with community-based organizations. What does a successful surveillance program look like, etc. Another aspect of perfection that we need to let go of is related to the alignment or coherence of a set of indicators. This one's a little more subtle, but has been an important challenge in our work on this to date. So let's return to this image of the various stakeholders with an interest in measuring success. We have needed to accommodate the respective perspectives and interests when identifying measures. And as a result, we sometimes end up with a set of measures that feels a bit like a hodgepodge. So here are some oversimplified examples of this using STD surveillance data and some domains of approved STD/PCHD performance measures as examples. So take STD surveillance data. This is largely used to measure and report on the state of STDs more broadly, nationally. Healthy People 2030 relies a lot on STD surveillance data, for example. Then look at STD surveillance data completeness measures. Those are largely for internal program improvement. That information does not get shared up the chain much. You can take disease investigation and intervention. As I showed before, we use those measures primarily to assess performance of our funded STD program and for program improvement. This is not something that appears in Healthy People 2030, right? But it is something that would get reported up as a part of general progress on the STD/PCHD cooperative agreement. It's a major emphasis of that work. And then now look at HIV prevention measures. In the case of STD/PCHD in particular, there are as many measures about this topic as for the entire surveillance portfolio. This may seem imbalanced, but these measures inform ongoing relationships between the STDs and HIV fields. They have a special purpose and audience. This imbalance is purposeful and has good reason. And then the last aspect of perfection we need to let go of is related to data quality. We know that data quality issues are common. Here is a sample of data quality issues that recipients have shared with us related to female syphilis partner services measures. So, and you know these issues, right? Problems with linking records, problems with data missing, what data was available at the time of download. Data used to measure performance is never perfect, right? But we cannot allow that to paralyze us. And similarly, there are other concerns that abound about performance measurement, such as unfair comparisons, concerns about punitive consequences, and the fact that so much outside of our collective control affects our ability to progress or perform, much less succeed. And COVID-19 obviously puts a fine point on this issue. I think that better understanding and accepting all of these imperfections can help reduce frustration and confusion, both within CDC and by health department partners, about the list of measures and the data gathered. Hopefully, this can help increase buy-in for data collection and facilitate more collaboration around report out, interpretation, and use, which I'll come back to in a moment. And to move beyond these, we found a few things have helped, but it's still something we struggle with a lot. First, we started to lead discussions with the issues, not the data, right? So let's have a webinar about partner services for women with syphilis, not a webinar about performance measures about partner services, right? It sets the stage where the data can be brought in as appropriate to the discussion, right? It's easier to have a fruitful discussion, even if some data available are not as strong as we would have liked. We've also been careful about how we share reports. The report snapshot I shared earlier, for example, is not on the web. We believe this helps health departments feel better about sharing data that have limitations. We're also committed to doing more to tailor reports for different audiences to ensure there's appropriate context and messaging. Finally, we're trying to do more to involve project officers and others who can couch measures and metrics accordingly. By involving more people who know the context for any data, we can have richer discussions and move around all the limitations we know about and help home in on what we can glean from the indicators and data. And overall, all this sort of boils down to trust, particularly between CDC and project areas, to entrust us not to misuse the information or allow others to do so. And so this is a major ongoing effort. And then briefly, I want to move to my final point about the need to reserve more energy for use. So here is how I have observed the process of measuring success. And like all the other points I'm trying to make, I have been entirely complicit in this. We expend a great deal of time and energy identifying measures, talking about what might be good to measure and why, developing templates, etc. Then by the time it's time to gather and submit data, there's a little less energy available. Still pretty good, but it's a little less. And then when the data get to us, we have some time and energy to produce good, readable reports, but that time is still half that expended identifying measures. Then once we have the reports, the time and energy left to reflect on the data, discuss the information, much less use it for program improvement, is very low. And if you remove this last step, really the other effort goes into a garbage can. I won't even say that it's a recycle bin, right? This is tragic. And I don't have a lot of successes to report in this area, but I can tell you that it's top of mind here at CDC. We have set evidence of use of performance measurement data as our own measure of success for the overall endeavor of trying to do performance measurement. So to increase use, we need clearer prioritization of the measures and the issues they reflect, especially from leadership. When bandwidth is limited, it requires leadership to say, yes, we need to make time for this, and here is how and when, and what we expect you to do with the information. And greater prioritization cannot be made without a lot of collaboration and flexibility to go along with it, right? We can't expect each measure or issue to be equally prioritized by our stakeholders in every project area. We have to be flexible about when and where and how we push a performance measurement discussion with whom. Then maybe we can sort of reverse the energy curve going forward. So in case you missed them, here are my main points again. And I just wanted to end by relaying some of the steps that we are taking here in the Division of STD Prevention on some of the points within our work as we prepare for the reporting of new performance measures and for putting that information into play effectively. So it's just a sample of things we'll be working on. I'm not going to go through them all. We won't get it all right, of course, but we are working towards relative progress and improvement. And some are steps that health departments can also take to improve their approach to measuring success and using performance measurement data within their own organizations. Okay, well, that's it from me today. Thanks for your attention, and I look forward to hearing the perspectives of my fellow speakers on the general concept of measuring success. Here's my contact information and acknowledgements to various people and teams that help me think through these things. Thank you.
Our next speaker is Dr. Erica Samoff. Dr. Samoff is the lead for the HIV, sexually transmitted disease, and hepatitis surveillance team at the North Carolina Division of Public Health, Communicable Disease Branch. She received her PhD in epidemiology from the Yale University School of Public Health. Prior to working at North Carolina Division of Public Health, she worked for local health departments and for the CDC. Her current focus is on gathering and analyzing disease data so it can be used effectively. Her ultimate goal is that North Carolina residents and all of you have the opportunity for a healthy sex life. Today, Dr. Samoff will be presenting on defining and measuring success for STI surveillance, local program experiences.
Good morning, everyone. Good morning, colleagues. It's nice to be with you. I wish I could be with you in person, but barring that, I'm happy to be with you this way. So I'm going to talk about measuring success at the state level, and I so appreciate Marion's focus on using the data. My presentation is actually divided by use case. So as we go through, I'll identify the user. I'm going to talk about the basics. Is the system functioning? Telling the story, identifying the goal, defining progress toward the goal, and rallying support, and being powerful. I know that's not something we usually think about in STDs, but let's think about it. And I will say that I'm coming from a surveillance perspective, not a clinical perspective. So that's my focus. So let's first talk about the basics: processes, outcomes, and adaptiveness. And the user here is the STD program. We want these data to be usable in the hands of people who are improving a surveillance program or an STD program. So I'm going to give you 3 examples of ways that are important for us to measure success in North Carolina. This one addresses processes. We were looking at our reporting time, and we got the feedback from our staff that we're late because the local health departments are slow. We always have to send cases back and forth. And this is showing you 2015 data. I didn't have time to update everything to 2019 because of COVID-19. So some of these data are older, but the point is still relevant. So we asked ourselves, we dug into our data, we got really down into the nitty-gritty and looked at how often cases were being passed back and forth. And I'm not going to go through all the details here, but what we learned was that, as you can see in the chart, although cases that are assigned back and forth more than 3 times in orange do take longer, only a small proportion of our cases were assigned back and forth in that way. So, and anybody who does surveillance will be familiar with this, the obnoxious ones were sticking out. What's the point? We have to be not only looking at our outcomes, but deep in looking at our processes in order to improve things. Okay, my next example is an example of outputs. We need to be measuring outputs. I think the obvious output that we pretty much always measure is demographics, cases by population. And of course, that is very important. We need to be looking at who we need to talk to, and we definitely need to be looking at disparities. But I wanted to point to these other measures, which are more about care. Our best approach to actually reducing STDs is rapid and effective access to care. So we need to be looking at our outputs for these care measures. How complete is our provider data? Can we reach out to our providers from our provider data? How good is our treatment data? How good is our HIV status data and pregnancy status? We do okay in North Carolina for some of these, not so well for pregnancy status. But as a user, as an STD surveillance program user, I want to be measuring my processes. I want to be measuring my outputs. And then there's one-offs or new measures. Ocular syphilis is a new measure that we had to implement in the past couple of years. I'm going to show you an example of using apps to contact partners, but I wanted to highlight this because there's a cost here that we have to be aware of funding appropriately. If there's something happens and you can't see it, you can't measure it. If you need a new view, if you need to be able to measure something, you need to be able to adapt your system to capture it. And you have to fund the system enough to make that possible. So what that really means is you have to have enough IT staff time to adapt your system on the fly. And I have a million times run into not having enough money for this. So at some level, we need to be measuring money or at least feeding back into the budgeting discussion in order to be able to be effective at surveillance, at our surveillance process, and measure these one-offs or new measures in a reasonable time scale. So an example here is, these are websites or apps that people are using to find partners in 2018, and it's by region and by partner type. So this is, first chart is MSM, and this was information that we were sharing with our regional DIS offices so that they could be aware of where they needed to be, at least familiar with how the app worked. And you can see for MSM that they're using Grindr and Jacked and Adam for Adam, where they were in 2018. But the thing to know about this is that it's very dynamic. what websites people are using changes. And the way we have it set up in our surveillance system is we've got checkboxes for the most common apps, and then we've got another field for other apps that people may be using. And what we do is every year or so, or every time something pops up that seems like it's suddenly a lot, we look at that text field and we alter what's in our checkbox range to reflect the most common apps. That makes analysis a little complicated. You have to pull the text out from the text field and categorize it and match it up with the checkbox fields. And we'll thank Anna Cope for doing that analysis for us. But that adaptability allows us to do a better job at completeness for the apps. So this is MSM findings. This is women. Women are using a very different set of apps: Facebook, Plentyfish, and Tagged, and Tinder. And then men who only have sex with women are mostly overlapping into the same apps that the women were using. The last thing I want to say about the STD surveillance program user and knowing your business is running is, are people accessing the data that you're putting out? And so I wanted to point to measuring page clicks. These are page clicks for our annual reports, quarterly reports, and fact sheets. And that was this kind of a complicated measurement to develop, but we are now measuring it, and I would support measuring it to the rest of you. Okay, that was from the use case or the user view of the STD surveillance program user. Now let's talk about telling the story. In this case, this is what Marian defined as informing a key stakeholder. The users here is anybody who's going out and talking to other people about STDs, and that's a range of people from leadership to disease investigators to community-based organization staff. We want to be putting out materials that point to a goal, that measure progress toward the goal, and are useful in rallying support. So what I'm showing here is a syphilis fact sheet, and I put the web page for our fact sheets at the bottom here on the left. We have fact sheets for every disease, and then we have fact sheets for different kinds of views, like we have women fact sheets, and we have health equity and people who inject drugs. So it's a way to encapsulate a story and put it out on the web. These are written mostly at a provider level or a local health department staff person level. They're not a 6th grade level tool, but there could be a version of this that's the 6th grade level tool. So these are designed to tell a story. You can see here the turquoise titles are written, they're not like syphilis rate in 2018, comma North Carolina. Instead, it tells the actual story. Rates of syphilis are stable in North Carolina in 2018, but continue to increase nationally. The front page has the key data stories that we want to tell. Gay, bisexual, and other men have the highest rates. People living in poverty have the highest rates. And then on the back side, the back page is where we point to the goal. So you can see the top title here is most people are treated within 2 weeks of their syphilis diagnosis. However, only about a third of those with symptoms are treated on the day they're seen. So our goal here is to reduce time to treatment. Our chart shows in particular people who were treated on the same day, people who are symptomatic and treated on the same day. And you can see that those proportions are less than 50%. And then the bottom half of this page tells people what to do. Here's the goal. We want you to assess for STDs for STD risk factors at every visit. We want you to screen syphilis patients for other STDs, and we want you to immediately treat any patient with signs or symptoms of infectious syphilis without waiting for test results. We're bundling our measures. Here, first of all, we're defining an access to care measure. Then we're bundling our measures with instructions. We're putting our measures in a context that points to the goal. And then finally, we're equipping people with a tool to rally support. So the way that these fact sheets are made, the titles are the main line of the story, and the bullets are basically a script. So that anybody, whether they're a leadership person who doesn't have their head in STDs all the time, or a disease investigator who's talking to a doctor who they may not feel that they're on the doctor's level, or the doctor may not feel that they're on their level until they convince them, anybody in that range of people can read through the bullets and be informed and effective at communicating our message. So the measures here are basic measures. There's the rate of disease, there's the rate by sexual partner preference, there's the rate by area in poverty, and then there's a treatment measure. But the package of it allows us to reach out, tell the story, point to the goal, and rally support. Okay, the last thing I want to talk about is being powerful. Like I said, we don't usually think about that in STDs, but let's think about it. This relates to Marion's use cases of the state of the nation and internal program improvement. And the user here is somebody maybe more senior who's at the health department level for the state, or the leadership of the STD program tapping into a state level process, or a health system operator. So thinking about how to have power, I'll borrow something from Matt Golden from the last STD conference. Success combating generalized epidemics like chlamydia and HPV depends on intervention at the health system level. Success combating concentrated epidemics like HIV and syphilis requires dedicated specialized infrastructure. So thinking about how do we operate at the health system level and how do we operate as infrastructure? And since we're talking about measures here, how do we get our measures to operate at those levels? So of course, major health systems have lots of measures that they look at. And here's some examples of what could be very powerful measures. In Centers for Medicare and Medicaid Services, they use a HEDIS measure, which is a managed care measure. They look at chlamydia screening in sexually active women. That's calculated for all managed care programs, although you have to pay to get the data. The Trust for America's Health Rankings uses chlamydia rate, and maybe some of you have found your state or your county shining in America's Health Rankings because your chlamydia rate's particularly high that year. Federally qualified health centers have a number of measures. For STDs, they measure number of STD visits, which is maybe not exactly what we'd want, and maybe that's a place where we'd want to tap in and try and affect that measure. They measure vaccines but exclude HPV vaccine. And finally, the example I'm going to talk about is something like a Healthy 2030 goal or a goal linked to accreditation that are state level goals. There's lots of barriers to having power. I'm sure you all are aware. Here are some. Not having the data. Like, for example, we wanted to include syphilis as part of our infant mortality measures, but we don't have data on syphilis screening during pregnancy, so we couldn't get it in there. Not having the measure. For example, most of these programs don't include anything about gonorrhea. Or having the measure, but people don't care. And that HEDIS chlamydia measure is an example of that. That measure has been low, like between 40 and 60%, I think, overall for years. And it's not changing. So there are barriers to being powerful. But by being present in these measures, it at least gives us access to these infrastructure and health system level discussions. So what I'm going to do, my last piece here is an example of trying to get a measure into one of these systems in North Carolina. So here's our use case. It was our state Healthy 2030 goals. Our Healthy 2020 goal had included, in North Carolina, our Healthy 2020 goal had included 2 STD measures, the % positive for chlamydia and the rate of HIV. But for Healthy 2030, they wanted us to get it down to 1 goal. Our goals were, in this year, this was 2019, so it was the year of ending HIV. We definitely wanted to retain the HIV measure, but we also wanted to have an STD measure in there. We didn't want STDs to drop off the windscreen. And our HIV measure was in a behavioral health measure. It was in the category of behavioral health. And we wanted to try and reorient the measure that we gave them to point to access to care. So we asked ourselves, can we combine STDs in an access to care measure? We tried to design a measure that would combine outcomes for STDs and HIV. So what that does is it focuses on integrated care. If we put those numbers together and make them equal, then we're saying we want you to care about sexual health. At least we want you to care about sexual disease, sexually transmitted disease. We're not going to set these systems apart. We're going to measure them together. They should be integrated, right? But at the same time, it keeps the measure relevant for ending HIV and allows us to make those resources part of our picture of addressing the measure. We wanted to look at timeliness of treatment because, as I said, effective access to care is the best way to address STDs. And it helps us identify settings where we can intervene. So we invented a measure, and here's the math for it, and you can see it on the right. Let me just orient you to this little bit of table on the right. There's the unweighted totals. There's slow treat, which is the cases that were treated that failed timely treatment, that had a slow treatment, and then the total. And so unweighted on the left and weighted on the right, and the diseases are down the left column. So I'll tell you what this math is now. We defined a timely treatment window. For chlamydia, gonorrhea, and syphilis, we wanted to see treatment within 7 days of diagnosis. And for HIV, we wanted to see linkage to care within 30 days. For each case, we classified them as timely treatment or not. So then we had a number of cases, total number of cases, if we lump them all together, chlamydia, gonorrhea, early syphilis, HIV, add it all together. We have a number of cases that weren't treated timely, and we had a total number so we could get a percent. But if you think about the relative number of cases, you can see that chlamydia is going to outweigh all the others. In North Carolina, there were 60,000 chlamydia cases or so in 2018, and about 1,300 HIV cases. So in order to address that problem, we weighted the other diseases, and that's what's showing in the chart on the right. We took the total number of gonorrhea cases, we divided chlamydia by gonorrhea to understand the relative proportion, and we created a multiplier that gets our total number of gonorrhea cases up to our total number of chlamydia cases. And then we took our numerator, which is the number treated slowly, the number that failed timely treatment, and our denominator, and we multiplied them by that multiplier. And then we added them all together. So I'll show you what that looks like. In the top chart, you can see the proportion that were treated slowly for women in green and men in blue. For chlamydia, gonorrhea, syphilis, and HIV separately, that's the left side. So you can see that women were more likely, there was more difference between men and women for chlamydia and gonorrhea than there were for syphilis and HIV, and that women were in fact quite likely to be treated slowly for chlamydia. And then the darkest bars on the right of the top chart are the composite measure. So we put all the diseases together. You can see that it's dominated by the other STDs, and it doesn't lose the story of the other STDs to the HIV. But it's not as high like it's chlamydia. You can see it's something like an average. So then the bottom left chart shows that measure by setting. So in order to put the settings together, we had to match between the EHARS setting categories and the setting categories that we use for STDs. That was mostly pretty doable. And I made some really big lumps here, lumped them together, so bear with me. What we see looking at the composite measure by setting, keep lumping women and men together here, is that in private settings, in hospitals, and in school-based clinics, treatment was really quite fast. Most people got very timely treatment. In HIV counseling and testing settings, and family planning and correctional settings, a lot of people weren't treated timely, and STD clinics were in the middle. So we thought this was a pretty usable measure, and it has this value of putting the eye on integrated STD treatment. We pitched it. Unfortunately, this all got developed like rapidly, and we pitched it like a day or two before the measures were due. And it was just too novel to be accepted. So we did not actually succeed at having power in this moment, but I think there's something here for development. What we ended up with in our Healthy 2030 plan was the HIV rate and no STD measure. But we do have STD measures as part of our End HIV plan. And I guess our future step is to continue to reach for power and develop this measure further. That's all. Thank you all for your help. I want to acknowledge the people here who provided comments and thoughts, and my contact information is on the right.
Our next speaker is Dr. Julie Dombrowski. Dr. Dombrowski is an associate professor of medicine at the University of Washington and deputy director of the Public Health Seattle and King County HIV/STD program. Her research focuses on improving HIV and STD clinical and public health services in the United States. She has worked with the HIV/STD Partner Services Program and STD Clinic in Seattle for 11 years. Today, she will be presenting on metrics around successful partner services, linkage to and monitoring PrEP and HIV care. Dr. Dombrowski?
Thank you very much for that introduction. I'm really pleased to join this discussion today. And after hearing Marion's talk, think that perhaps a better title for my talk would have been Sharing Progress in Partner Services Related to PrEP and HIV Care. So I think we will undertake it in that spirit. So I will begin today's talk by discussing the context of and rationale for expanded STD partner services activities. And then I'll discuss metrics for PrEP linkage and HIV care engagement services as a part of STD partner services. And I'll finish up by describing what I think are 4 key steps to meaningful measurement in these areas at the local health department or state health department level. Importantly, I am giving this talk today from a pre-COVID perspective. Many of the staff and resources that are typically dedicated to STD partner services are currently redeployed to COVID contact tracing and likely to remain that way for the near future. But I don't know what the post-COVID reality is going to look like. And for the purposes of this talk, I'm going to essentially ignore COVID for the sake of discussion. The context of STD partner services has evolved substantially over the last several years. It's worth remembering that STD partner services really initially developed for syphilis control in the post-World War II period, and many of the methods that we have traditionally used in partner services aren't applicable in today's world. Communication technology has substantially altered the social organization of sex. STIs are increasingly concentrated among MSM, particularly young MSM of color. And most importantly for this talk, HIV prevention has been revolutionized by PrEP and recognition that U equals U, or undetectable is untransmittable. Primarily due to changes in HIV prevention technology, the activities of focus for STD partner services have increasingly moved beyond their initial purpose of partner notification, testing, and treatment for STDs to include an emphasis on HIV testing, referral for PrEP when appropriate, linkage to HIV care for newly diagnosed persons, and engagement in HIV care. And since these activities are broader than the initial focus, in some ways, field services perhaps better captures the activities we're talking about. And field services for STD can certainly go beyond HIV-focused activities to include things like working to increase the use of effective contraception among people of childbearing potential who are diagnosed with STDs, or linking people to insurance, especially in Medicaid expansion states for those who are eligible. For the remainder of my talk today, though, I will be focusing primarily on referrals to PrEP and re-engagement in HIV care. And as we continue the discussion about metrics, I think it is important to really distinguish process metrics from outcome metrics. Process metrics are the steps in the process, essentially the work that we do. And for traditional partner services, this includes things like the number of cases closed, the speed of initiation and closure, partners elicited and contacted and interviewed. Outcome metrics, on the other hand, capture what the processes accomplish. Essentially, what are the most meaningful outcomes of the work that we do? And sometimes we can get caught up on process metrics because they are easier to capture and easier to focus on for quality improvement work. But it's really crucial that we continue to try to capture the harder metrics of whether our work is actually making a meaningful difference in the world. How many new cases are we finding? How many infected partners are we bringing to treatment? So this slide first describes some of the metrics, both process and outcomes, that I think are important to capture for referrals to PrEP. First, we need to identify and clearly describe the priority populations for PrEP referrals. This can include both index cases and sex partners, but not generally all index cases or all sex partners. So we need to define at the local level and based on our local epidemiology, who are the key and priority populations for linkage to PrEP. Although that needs to be driven by local epidemiology throughout the US, men who have sex with men and trans persons who have early syphilis or rectal gonorrhea are undoubtedly more vulnerable to HIV and should generally be offered PrEP. So the proposed metrics on the right are shown here with the number or proportion of cases who first meet criteria for referral, the number or proportion who accept referral, the number or proportion who initiate PrEP, which is harder to define, and the number retained on PrEP, much more difficult, but possible, I think, perhaps in the longer term. So in this slide, I'd like to show an example of the metrics for PrEP referral in partner services in practice from our health department here in King County. So we looked at this over a time period 2014 to 17, starting with over 3,700 HIV negative MSM interviewed for partner services. We collected data on PrEP referrals for 87% of those. 41% were already on PrEP at the time of the STD partner services interview. Of the 59% or 1,900 who were potentially eligible, the partner services staff were able to offer referral to half of those. And the 50% proportion, I think, reflects a combination of the fact that we weren't offering it to everybody with all MSM with an STD in the beginning, but also that this is, of course, real world data. 53% of those accepted referral, and about half of those we were able to confirm initiated PrEP, or estimate, I should say. So these are the program evaluation metrics, those offered, accepted, and initiated. And I also want to emphasize that collecting data on PrEP use in partner services has the additional advantage of providing a sentinel surveillance metric, and that is PrEP use among MSM or otherwise defined persons with STDs, something that gives us a sentinel surveillance data in a key population in our area. So now let's transition to re-engagement in HIV care. This slide shows some proposed metrics for re-engagement that mirror those we may use for PrEP. And in contrast to PrEP, these outcomes, like the number relinked to care and virally suppressed within 6 months, are generally much easier to measure than the PrEP metrics, in large part because we have HIV surveillance data. It's really the process of re-engaging people in care and the process of identifying people who need that service that's generally more difficult than monitoring the outcomes for this activity. One example I'd like to highlight in this regard is the state of Mississippi, where the STD Partner Services Program has designed processes to identify people who are not virally suppressed or out of care at the time of a syphilis interview and work to relink them to care. And in the first year or so of that activity, they were able to confirm that half of the cases who were virally unsuppressed or out of care at baseline did relink to care. I think of this activity, identifying people diagnosed with an STD who are out of care and re-engaging them, as an important component of data to care, essentially using the data we have, getting people back in care. And effective data to care really requires multiple ways of identifying people who need re-engagement services. And I do think STD interviews are one important opportunity in that regard. This slide looks at the concept in a slightly different way, comparing locally our data to care activities, including STD partner services, and the number needed to interview to find one person who's out of care or virally unsuppressed with HIV. And at least for us in King County, the primary and secondary syphilis interviews are a more efficient way to find people who are out of care, and takes less, it's essentially more efficient, less time than things like using HIV clinic data and HIV surveillance list, where really the minority of cases that we investigate rather, and are able to contact are truly out of care. And on the right, compared to our data exchange activities that are essentially set up to automatically identify people out of care, those are the most efficient. So really the key point of this slide for me is that although it will vary geographically, STD Partner Services is a relatively efficient way of identifying people who are out of HIV care or virally unsuppressed. This metric, number needed to interview, or NNTI, is a key outcome metric that can be used in many ways. As I just used it to look at data to care in King County, it's really a measure of efficiency. And for that reason, it can help guide prioritization of our activities. It can also help highlight geographic differences, comparing across states or across local jurisdictions, and can highlight disparities, particularly racial and ethnic. So here's an example of 2 papers that use the number needed to interview as a metric for finding new HIV cases as a part of syphilis partner services. And as you can see, in North Carolina, the number needed to interview among all syphilis cases to find one new case was 43. In Mississippi, it was higher at 64. But when examined by race, the number needed to interview among MSM was substantially lower, as would be expected with higher rates of HIV among Black MSM compared to white MSM. Okay, so let's switch gears now in the last few minutes of the talk to talk briefly about barriers to measurement and transition into some key steps that we are all trying to take, I think, to achieve meaningful measurement for HIV care and PrEP. So first, disconnected systems. As was mentioned in, I think, both earlier talks, using different data systems, trying to link those can be extraordinarily challenging. And especially for activities that require relaying cases, such as referrals for PrEP or relinkage to care to other staff, navigators, for instance, in many areas. Sometimes those referrals simply drop into a void. It's very difficult to tell what happened after the DIS or partner services staff referred that on. Very often, partner services staff have difficulty doing this work because they don't have access to the data that they need. So ideally, DIS, when they're doing a case investigation of, for instance, a syphilis case and reaching out to interview, would know someone's HIV status, at least as far as we know it in HIV surveillance, and the date and value of their last viral load. I think it is essential for people doing STD partner services work to have easy access to EHARs. And then our data systems, which are continually challenging, not just multiple, but how we use our individual data systems. It's often very hard to change the data fields to support this work. Very often data that we want to look at for our measurements are not collected in extractable fields and rather are described in narratives or in text. And even when there are extractable fields, it's still difficult sometimes to extract that data for regular and routine monitoring reports. So how do we overcome these barriers? Well, with first a lot of creativity and tenacity and persistence and learning from our peers. But more specifically, I think there are at least 4 key steps to help us think through how to achieve effective measurement. And my comments on this topic are informed by some learning collaborative work that our group did with several health departments around the country. So first, we need to define the priority population. This is relatively clear for HIV relinkage to care, but less clear for PrEP. So that really needs to be local. It needs to be defined as a priority population, clear which group we are measuring these activities in, and it really has to be a measurable and definable group, right? We may come up with priorities that we can't identify or define in partner services. We need to focus on measurable definitions. So that may be MSM, it may be defined by race, ethnicity, really a priority of addressing inequities, maybe focus on younger populations, or perhaps by STDs such as syphilis, which really confers the highest risk of HIV acquisition. We need to identify the data sources we'll use both at the time of the interviews and to look at these outcomes. So at the time of the interview, how will partner services staff know the information they need to know to direct these activities, and how will we confirm those? As I mentioned and alluded to, we really need extractable data fields. As we're improving this, we need to question whether we can change the current system, and if we can't, start to think of alternatives. So we can't hold up these activities waiting for the data system to change. We need clear definitions of case dispositions. For instance, a case being in HIV care needs to be clear whether that was at the time of the interview or after activities to relink someone. And then periodic report review, getting back to the idea that came up in, again, both prior talks of really using our data over time to inform our ongoing quality improvement. So I think it is important to clearly define how often do we look at these reports, who generates them, and what is the mechanism? Is it distribution by email? Is it in-person meetings with the relevant folks to talk about what's happening with the metrics? So in conclusion, STD partner services are increasingly focused on ensuring access to HIV prevention and care, and we need to measure both process and outcome metrics. This requires clearly defined priority populations, data systems, and data collection tools to support this work, and a mechanism for ongoing report review and quality improvement. In the context of COVID, I recognize that in general, only the highest priority work is getting done, but at least for many areas, this does continue to include linkage to PrEP and HIV care re-engagement. So I'd like to acknowledge the many individuals who have contributed to some of the ideas discussed herein, and colleagues from many health departments who participated in the learning collaborative relevant to this work. So thank you very much, and I look forward to our Q&A session.
Our final speaker is Dr. Acknowledgements. Dr. Acknowledgements is a physician researcher and an associate professor of internal medicine and infectious diseases at UT Southwestern Medical Center. She completed her medical school and internal medicine residency at UT Southwestern, her infectious diseases fellowship at Massachusetts General Hospital, Brigham and Women's Hospital, and her research training at Brown Medical School and the Harvard School of Public Health. She sees patients and conducts research in the inpatient setting, the outpatient clinic, and at the Dallas County Jail, with a focus on HIV and sexually transmitted infections in vulnerable populations. She will be presenting on successes and challenges, a long-running STI screening program in a correctional setting. Dr. Acknowledgements?
Thank you for that introduction. It really is a pleasure to be here today and to share the stage with these wonderful presenters. So I'm going to speak today on successes and challenges of STI screening in a correctional setting. And I wanted to start, I have nothing to disclose. I'm going to give you a little bit of background about incarceration, just very briefly, since it is a little bit different from what we've been talking about, but I think there's a lot of links to what we've heard already, and just the overlap with incarceration and sexually transmitted infections, and then get into some of the successes, which I agree we always get a little nervous about calling anything a success, but also, and the challenges involved in this work. So I first want to just remind everybody about incarceration in the United States. And so we, in fact, in the US lead the world in the rate of incarceration per capita. So you can see here on this graph, 707 per 100,000 individuals in the United States are incarcerated. We're way ahead of Russia, Ukraine, and all of these other countries listed below. And so even though the US is about 4.5% of the world population, we incarcerate almost 25% we have almost 25% of the prisoners in the world. So this is a large population. Okay. And this has not always been the case. This has increased over time, particularly around in the early 1980s. With the quote unquote war on drugs, we started to see a marked increase in incarceration. And here you can see both jails and prisons. And just as a reminder, so jail is where people go after they're arrested. It's typically a short stay. And from there, they may get transferred into prison if they're sentenced. And prison is somewhere where people may stay a year or longer. And currently we have over 2.4 million people who are incarcerated in the United States, and then also many people who after incarceration are on probation or parole. Okay, so why is this relevant? So this is a very large population, particularly with jails, can be a very fluid population, people coming in and out. And I think in terms of infectious diseases, so I'm an infectious diseases doctor, I work in the jail. And this is really such an important place to work because of the prevalence of infectious diseases here. And when you start to look at, I think this is a really interesting way to look at these infections, is think about the proportion of people as they're released from jails or prisons, what percentage of the total US population they represent with that particular illness. So I would highlight on the far right with HIV, the number of people with HIV who cycle through the correctional health system and sort of the proportion they are of all people in the United States with HIV. And then on the left, if you look at total STDs, and these are estimates based on, you need to, of course, have good national estimates, and then also within the jails and prisons. So there are some limitations to measuring this, but just a huge proportion of people coming out of jails and prisons, they represent nearly a quarter of all the people with STDs in this country. So such an important place to look and manage these infections. And the CDC has really been a leader in measuring this. So here is just an example, looking at chlamydia in particular. And I like how this graph is set up. So on the left, you have men, and on the right, you have women. And then it measures positivity rate, and then by different age groups. So as you might expect, the younger age groups, so on the top, you're seeing higher positivity rates for chlamydia, and then as people in older age groups, you don't see quite as much. If you just make a relative comparison, so at the same time period of chlamydia, for example, in males, general prevalence is around 1.4% across age groups, and then for females, about 2%. So you can see that just the prevalence in this setting is going to be many-fold, maybe 4, sometimes 5, 6-fold higher in the correctional setting. And this is a study that I did way back when I sort of one of the first research projects I did, looking at trichomonas, and it just was a good opportunity to mention it. I feel like trichomonas is sort of the forgotten STD. And so, but I think what was compelling about this is just the comparison between people who have been incarcerated or not. So this actually is data that comes from the HERS study, which is a longitudinal study of women with HIV or at risk for HIV who had then visits every 6 months. So you can see across the bottom, those numbers 1, 2, 3, 4, those represent 6-month visits. And then on the left is percentage of women who are testing positive for trichomonas. And so dark black is women who had not been incarcerated in the interim between those 2 visits. And the gray bars is women who had been incarcerated. So overall, rates of trichomonas were very high in this group, which was a high-risk group. But then you can see incarceration really increased that rate of detection of trichomonas much higher. And so compared to the general population, about 3%. And then in women who are incarcerated, much higher, as much as 8 to 31%. And then I wanted to highlight, because this is something I see as when we're talking about successes in this setting, I think this is such an impressive data or impressive study. If you look at, so this is the white bars are 2004, black is 2005, and gray is 2006. And so this shows over time chlamydia cases. This is among men under 35. And then you can see the different groups of bars are by different settings. So you have the STD clinic, adult jail, et cetera. And so the biggest change here from 2004 to 2005 is what the jail implemented routine screening for chlamydia in men under the age of 35. So not symptom guided, which is what they have been doing before, but if you were under the age of 5, you were tested for chlamydia. And so in 2004, they had 222 cases. The following year, when they did this routine testing, they have nearly 4,000 cases. That's an increase of 1,636%. And you can see that this was sustained over the following year. And so I think just highlights the importance of screening in this setting, and also the importance of routine screening and not doing just symptom-guided screening. And I think so when you think of sort of examples of failures or challenges, is when those kind of programs go from losing their funding or we're not able to do that type of screening. So I think this is very similar, but in the opposite direction. So you can see on the left, this is Cook County area in Chicago. And they had been doing routine screening for gonorrhea and chlamydia in males, so similar to what was happening in New York. And you can see on the left is when they were doing that, you'd see where all the cases are coming from. The black triangles are gonorrhea and the white circles are chlamydia, so kind of all over this area. After that year, they lost their funding to be able to do that. And you can see the map on the right, the numbers are far, far fewer, and it's not that this went away, but they went from, instead of routine screening to symptom-based screening only. So they went from nearly 3,000 cases to 243 cases. So it really is the exact opposite of that study in New York, and a decline of 1,100%. So, the sustainability of these types of programs is really important. Okay, so thinking a little bit more about successes and what may be the elements of success. So first I would highlight a study that we did here at the Dallas County Jail, is looking at people living with HIV who had been in jail and testing, what kind of testing did they get for gonorrhea, chlamydia, syphilis, and then also hepatitis B. And so this is sort of a combined success and failure example. But what I would highlight here is, first, it's so important to look at the numbers. And we've been talking a lot about examining data, and this is so critical. So what you can see, this is amongst over 1,000, represents over 1,000 incarcerations and about the same number of unique individuals. And then were they tested for gonorrhea, chlamydia, syphilis, and or hepatitis B. And so you can see all of them were in fact tested for syphilis. The majority were tested for hepatitis B, but very few were tested for gonorrhea and chlamydia. So this to me is such, we know that this is so important to do on a routine basis. And clearly that was not happening. So we're seeing a very low percentage, only 17% were getting tested for gonorrhea and chlamydia, and yet syphilis testing was very high. And why is that? Well, the reason for that is that when they come in, people who disclose their HIV or we know have HIV will get tested, will get blood draws, and as a reflex, the syphilis testing is done. Hepatitis B is also typically done, but needs to be added on. And then the gonorrhea and chlamydia was collected separately with a urine test, and sort of the provider would have to do it, or the patient would have to request that test. So it really highlights that when things are integrated into existing processes or added on to existing blood draw, that we have a high rate of uptake or success, and less so when things are not made routine. And so this has since changed since this time, since we published these data. And now, in fact, the urine sample is collected prior to the patient even being seen by the provider. So we'll revisit those numbers and hopefully see much higher rates of gonorrhea and chlamydia testing. Another example, and this is actually going to be a poster at this conference presented by a medical student who I've been working with, Christine Deng. And I think these data are really exciting. So we, back last year, so near the end of the year, beginning of 2020, started, in addition, so all women, when they come into the jail, get tested for pregnancy. They get a urine pregnancy test, and that is routine. And we began adding on gonorrhea and chlamydia testing for all women under 50 at the beginning of the year. So this is indicated by week 15 and by this arrow here. And so you can see the orange bars are women, or the females, and then the bluish bars are males. No process change happened for the males. And so what I don't show here is that the number tested increased nearly 5-fold. And we were testing almost all women who came in, because all women are getting a urine pregnancy test. And I should also highlight that there's about 4 or 5 times more males than females. But you can see in the beginning, prior to this intervention, you have very similar numbers and these are just the positive results of chlamydia. And then when we implement this testing, the numbers of positives go up. So we in fact saw a similar increase in the positivity rate, about a 5-fold increase in the positivity rate. And so when we talk about looking at data, you can just see how compelling this is. In fact, our administrator had asked me, why are we spending so much money on these gonorrhea and chlamydia tests? And then when you start looking at the data and you see that with that investment, you're also seeing a really proportional increase in the number of positive tests, that you can see that is really valuable to do in this setting. And it's similar for gonorrhea. I'm just focusing on chlamydia here in this slide. And then another thing, so what I wanted to mention, sorry, just going back to the chlamydia, is making it part of, because it was something that was already happening. So we talked a little bit about, Dr. Dombrowski talked about process measures. This was already part of that process. So it wasn't an extra step that was required. And then look at this outcome measure, is that we're seeing this high rate of positives. Another thing that I think has been quite helpful is sort of alignment of priorities. And here I highlight Parkland. Parkland Hospital is our large county hospital system, which actually also runs the healthcare at the jail. So that in and of itself is an alignment of priorities and is remarkable. But under the Affordable Care Act, they're required every 3 years to do something called a CHNA, a Community Health Needs Assessment. And this is this involves pretty elaborate surveying of the community and defining different goals and needs, and then developing an implementation plan. And so, and they work closely with DCHHS, so with the Dallas County Health Department. And so this collaboration is really critical, and they identified multiple things to focus on, and particularly wanted to look at health disparities. Well, STIs and HIV were one of the things that they highlighted. And so when you look here, one example is, again, looking at chlamydia, is they identified what areas of Dallas are we seeing the highest rates of chlamydia, and what can they do to improve that. So first collecting the data and thinking about where these disparities are, and then thinking about ways to implement change, and with a focus on zip codes and geography, with a focus on health disparities, and also social determinants of health. And I would highlight here, this graph, again, also a map of Dallas, highlights where we have high incarceration rates. And there's quite a bit of overlap with high rates of incarceration and sexually transmitted infections, gonorrhea, chlamydia, syphilis, and also HIV. So I think that points out how when you have aligned priorities, you can have an increased focus, for example, on STI screening in this setting because it meets multiple goals. And there are many challenges, and I just wanted to highlight one key one here. And this slide I've also borrowed from Christine's presentation is looking at the paired urine pregnancy testing with gonorrhea and chlamydia testing and sort of the timing of that. So that test was collected and then sort of the median time to results being received and then treatment was over a week. And so only 56% of women with positive tests received treatment in the jail, which I think it's interesting. I think that was also pointed out in one of the other presentations of I think Dr. Samoff with the slow to treat in the correctional health setting. And so this is where you see challenges that even though we've integrated to an existing process, well, that process may need to change. It's not very efficient. And of course, if we're testing, we'd really like to treat people in this setting. Linking to STI treatment after release from jail is quite challenging to locate people and get them their results and connect them to care. So here's where I see a real challenge, is that although we've integrated into an existing process, maybe that process needs to be changed, maybe that needs to be made more efficient. So that's one of many challenges. I think I also highlighted already the loss of funding like we saw in Cook County, and that, that may not, STI screening may not be a priority at that time due to other things going on. So just to highlight in particular some of the things that we've identified as successes and challenges, and I think this really translates to a lot of different public health programs and a lot of what we've been talking about, but sort of regular data measurement and evaluation. If we didn't look at the STI screening rates in our HIV positive patients here in the jail, we wouldn't maybe have realized this glaring hole in gonorrhea and chlamydia screening. Just the importance of integrating into existing processes. So I talked about the syphilis testing being done routinely with HIV patients, but also this paired urine gonorrhea and chlamydia with pregnancy testing. And this is particularly important, I would say, in a jail where process change involves not only the medical staff, but also the security staff and getting everybody on board with that. I didn't highlight this as much as I should. So we have an internal champion who was really her idea to do our OBGYN here to do the paired urine pregnancy and gonorrhea and chlamydia testing, and had really pushed for that. And I think that's so critical, not only to getting things started, but to sustainability. And then what I mentioned, that this was aligned with the community, the health system, and our health department, which has been critical and has been really nice to have all of those priorities aligned and people wanting to see that regular data and evaluation. I think some of the challenges is this consistent funding. So programs may come in and say they want to look at this and they find high rates of STIs, but then it's not funded beyond the setting of a grant or a project. And really making sure that there's sustainable funding within the health system, et cetera. Changes in staffing, so if you have those critical champions that then move on to another position, or people that really were the linchpin in making these things happen. Some of the resistance to process change, and maybe I'm just being sensitive, but I feel like in the jail there's even more resistance to change. And that can be very challenging. So really making sure that you engage all the different stakeholders to do that. And then competing priorities. So if you're spending a lot of money screening for STIs, well, maybe you're not spending that money on other critical things. So I think that can be an additional challenge. I'm going to end there. I do want to have include some acknowledgements. So Dr. Jennifer Clark and Susan Cooven, who got me very interested in sexually transmitted infections, particularly in the correctional setting, and then many of other people that I've worked with, students, mentors, and collaborators here at the jail. And of course, the health system. So I think Parkland Health System, but also the county jail and our health department. So that's it. Thank you so much.
Okay, great. Thank you, Dr. Nijawan, for your presentation. And that brings us to the end of this symposium. And each of our speakers presented important aspects of this topic of measuring program success. What does it look like? How is it defined? real examples of identifying key metrics and how those can and should be used, and things we need to consider as we continue to plan, monitor, and evaluate STD programs and related activities. And there are common challenges that still remain, and that is the real world of experience of implementing programs and measuring program success from the federal level to the local level, as was presented today in the areas of surveillance, partner services, and screening programs. So Dr. Quilter and I want to thank our speakers for being part of this symposium, and to the audience for attending and for your attention. Again, I want to remind you that there will be a live 20-minute question and answer session for this symposium on Friday, September 18th at 2:50 p.m. Eastern Time. And we look forward to continuing the discussion on measuring program success with our speakers and conference attendees. So it's an area that is always relevant and more now than ever. So thank you, and this session is adjourned.